Hi, everyone. This is Dr. Jenny Hobson and Dr. Martha Cortes here on our fourth podcast called The Beauty of Breathing. This episode is so exciting. We're going to be talking about the Aqualizer study, and I have a special guest here called Bill Esser. He's a fellow physical therapist. Bill, thank you so much for coming. Martha, thank you for being here. I'm so excited.
Thank you.
This is our fourth podcast.
Exciting.
So let me tell you a little bit about Bill. Bill and I have known each other for years. We are the TMJ physical therapists. We know a lot about the jaw and how to heal this area of the body that people so much abuse and clench and really don't know how to keep resting in a way that's so relaxed. So what I want to tell you about Bill, he's a certified cervical temporomandibular therapist. We call those CCTTs. There's less than 100 in the world. He spent 4 decades evaluating and treating over 1,000 TMJ cases. He has presented at 2 national dental conferences in the relationship of posture and occlusion. Occlusion is the bite. So we're going to be talking about how the neck and the jaw and the bite all relate, which is so important. And then he teaches dentists and PTs TMJ, TMD treatment for the past 15 years, and 90% of his patients improve 90% in less than 90 days when utilizing that PT dental team approach. And that's what I'm trying to bring in with this podcast and Martha and I, because we both bring different parts of the picture. Martha is an excellent dentist of TMJ and airway. Well, we bring in the PT part. So Bill, Martha, thank you both. Thanks for being here.
Thank you.
You're welcome.
Now, I was reading the Journal of Craniomandibular Sleep Practice, and whose names do I run into? Can you elaborate about this article? Cranial is a big deal. I know Dr. Ira Shapiro for such a long time, and he's such a TMJ specialist. He's the editor-in-chief, and then he says, yes, it's Dr. Jenny. Can you elaborate on that?
Yes, I can. So Ira and I have known each other for a long while, and we help each other with common patients that we, share. I do a lot of the breathing retraining and the myofunctional therapy, and then I work on their cervical posture, their cervical lordosis, and their TMJ. And we always want that atlas, that first vertebra, even and leveled when you do so much of that dental occlusal work, trying to fix the jaw. So we need each other. Both of us need each other quite a bit. And one day, it was about 2 years ago, he reached out to me and said, Jenny, I need to tell you about this thing I know about this Aqualizer. I've been using this Aqualizer for years, and it's something that you need to know about because it's helped me with many of my patients. I said, what's the Aqualizer? What's this thing? Well, it's like a little appliance, a little splint.
Pillows, the little pillows.
Like little pillows that have, it's
Air.
almost like a little saline in them. So it's a little pillow fluid. And you can put it between your back molars, and it fits underneath your lips, either above or below. And what you do is, because everybody doesn't have a perfect bite, no one has a perfect bite, right? Sometimes the bite is a little off. Because of these pillows, there's something called Pascal's law. Well, that basically anywhere there's an imbalance, or one side being a little lower than the other, this little fluid sac allows a balanced bite at the end of, after you put it in, it fills in all the gaps. So the occlusion is taken out of the picture as part of the problem. It is basically neutralized. So this is what he said to me. He said, Jenny, every patient that comes in the door, I check their iliac crest height. I'm a dentist. I probably shouldn't be touching that low, but I know that there's a connection of the pelvis, the spine, and the jaw. So he tests that. He goes on, everybody's waist. He puts his hands there, and he sees, is one hip higher than the other? And what he did, and he still does, he says, okay, we're going to put this little aqualizer in your mouth. You're going to take a walk. And he has a staircase, so you can take stairs or just walk for 3 minutes. And he retests. And guess what? The hips, 9 times out of 10, evened out with this thing in their mouth. So something was happening where the bite was affecting the position of the pelvis. And he's like, we need to do some research here. We need to connect it to low back pain. And you know how many people have low back pain in this United States and in the world, but no one is connecting those two areas in medicine really that much. So he asked me to do it. And I said, you know what, Bill, Ira, I said, I'm a little busy. And he's like, no, Jenny, I will help you. Let's do it. So we ended up doing the study. It was about 30 people, a little over 30 people, that about 85% of those people ended up doing the study with me. I would walk them after I tested them, took pictures of it, found out what side was lower, what side was higher, took them on a walk on the treadmill, 3 minutes, brought them back, retested, and boom, they were even again. So then I was like, okay, what does this mean? Okay. And I said, I know just the person to bring into this picture, because Bill Esser is one of the best physical therapists in the world in this area. And you all need to know how smart and intelligent and inquisitive he is around this area of the body and the spine. So I asked him, and Bill, thank you, Bill, for joining.
I don't know if I should open my mouth now.
No, you have to. You have to. You have to.
Okay.
I still need your help, because you know what? One thing about Bill is he's a writer. Okay. He's been a writer for years with his wife that has been an editor. So learning from an actual editor, reading every single thing you write immediately, you learn how to be even better writer. And you've been doing this how long? How long?
Yeah,
40
probably about
years?
25 years.
Okay,
My wife,
25 years of writing.
she's had the correction whip on me for a long time. Yeah, so it's helpful. Jenny writes drunk, and I edit sober. So that's basically
He sobers my writing up. I say,
There you go.
he's like, write whatever you want, write drunk. And I said, okay, I'm going to write what I think. And then what Bill does is he cleans it up, and he cuts it
There you
down,
go.
and something that's this big is now this big,
Yeah.
which no one wants to hear.
It's an
Joe.
art.
It's
That's
an art.
That's an art.
Yeah. It's an
So
art.
Bill, this is where Bill comes into the picture. We were talking about this study. I said, Bill, you got to help me figure out what is happening, ascending, going up, and descending.
Going down.
How
Yeah.
is the bite and this aqualizer balancing it? How does it work? How do you think, in simple words, do you think, and we'll start, which one do you want to start with? Ascending or descending?
Let's go ahead and is this a visual podcast too, or just all?
Verbal.
Okay, so the physical therapists have been trying to convince dentists for 30 or 40 years that there's an association between what's going on in the head, above the neck line, and what's going on below. So I was working with a lot of dentists, probably 140 dentists in Southern Oregon. And one of them is bioaesthetic dentistry. And they came to me and they said, hey, we're having a little meeting. We'd like to have you come and do a presentation on a topic of interest to you. So what I found out, of course, was this little meeting was our national conference. And then speaking with me and about 500 dentists there. And the topic that I wanted to look at was, what are the ascending, what's coming from the bottom up affecting how the teeth come together? So the entire presentation that I presented to them was everything from the feet all the way up as it wraps around the head, wraps down onto the top of the temporal mandibular joint, has an effect upon the temporal mandibular joint and how the teeth come together. So I gave that presentation at the national conference for them for 2011, and then they had me come back and I did an update in 2015. And what I was able to do with the dentists that I worked with in that group was I would predict for them what side their teeth would hit on first. So when they were taking their models, et cetera, I would say, well, here's the head position. The eye is tilted up to the right on the right side. And if you take a look at the lip line, it's also up high on the right side and they're parallel to each other. And I'd say, okay, they're going to hit on the right side first. Okay, or they're going to hit on the left side. So in now 95% of his cases of his patients, he took pictures of his patients. I would able to say, I can tell you which side their bite's going to come together, how those teeth are going to match. Okay. And by the time I got done with the study with him, looking at all these pictures of all his kids and his patients coming in, I was going, did all these kids, with their heads on crooked, did the stork drop them on their head? Why? How? Or they run around, hit their heads against trees, etc., with helmets on. And I'm going, why are these heads consistently side bent to one side? Side bent to one side for so many of these patients. So I started looking at it the other way, Jenny and Martha. I said, could it be that how the teeth are coming together is driving the changes in the head position? So when you go back and look at the research, if you hit early on the right side, if your teeth come together on the right side first, it fires up all the facial muscles on the right side. And to balance that out, your neck muscles fire up on the right side and it pulls your head down and tilts your whole head mechanism and changes how your teeth come together. So I actually came to the conclusion that in many cases, especially younger people, it's the early contact or the uneven bite that's driving the alteration in the head position. So, yeah. So, and of course, anything that happens in your back, if you step in a hole and you twist your pelvis, or you have something going along the back muscles, they twist your pelvis and change what we call the functional leg length. It changes how long your leg may appear, and that changes your bite from the bottom up. So you've got both factors coming together. Yep. So yeah, it's a little bit complex there, but you got both effects coming up and effects coming down, and both have to be addressed.
Right.
Yeah.
Right.
And it's a little different too with orthodontics. With orthodontics, I was working with a lot of orthodontists, and I said, these kids are plastic. They're very malleable. So as soon as they change the bite for a lot of times for the younger patients like teenagers, et cetera, their head position would straighten out.
So fixing the bite would straighten out their head.
Would change their head if they weren't real stiff. But
Yeah.
the problem is a lot of patients have been in a side bent position for 4 or 5 years. Even when they're 15, they've been that for 4 or 5 years as they grow up. And you would change the bite on them. The head couldn't correct because too many structures, too many neck muscles, too many joints had tightened up. So we combined. We saw all these patients together. Anybody with a side bent head or a crooked head, or when they made their cast models or took a look, if they hit early on one side or the other, they got sent over to my office. I loosened everything up so their head could respond to what the orthodontist was doing. Yeah.
So I teach, I'm a clinical advisor, and one of the first things that we look at is the posture and all that, exactly what you're saying. And we find that 80% of the cases are left bend, C1 down, right, and shift to the left and up because the sphenoid is off.
Yeah,
It's the sphenoid, but the AO. So what you're saying is in absolute, and then you look at the shoulders, the hips, the knees, the arch. Are the arches collapse? Are there superpronation? So I agree with a lot of not a lot of physical therapy, pointed therapy, and it's the bite. So the key is to either aqualizer, which is brilliant, how to get those hips, but you got to get those horizontals on the upper jaw and the lower jaw. And that jaw has to come down and forward and get out of the way of the cervical. And really the whole body, the patients will grow 1 to 2
So
centimeters.
repeat that one more second because it just cut out. You said the jaw must grow and then it cut.
So in my world of clinical advising, one of the purposes it's always about the airway. So it's always transversing to open up the airway in the back, transversing. And because we transverse, the upper jaw comes forward a little bit, just develops. Point A goes forward 3 to 5 millimeters, but it gets out of the way for the lower jaw to be free, which comes down and forward. And we're able to get the head back on the neck. So I love what you're saying because it all translates down, but whether there's smooth compensation or the traumatic compensation is also important. So I love what you're saying. So thank you.
Talking
Now
about,
back to the project. Go back to the project. I find it so interesting.
So, you know, what we really realize is that if dentists and PTs use this as a tool, like if we really used it as a tool, we could affect this low back pain population because there's so many people walking around with leg length discrepancies. And I wanted to go back because Bill, you didn't really explain if you do have a leg length discrepancy, how that affects the lower back musculature. Like, and you know, I'm a dry needling certified therapist, physical therapist, and we put needles in people's backs when there's a trigger point. Well, I know that when you are uneven hitting, loading one side harder than the other, it creates a bunch of trigger points, and trigger points hurt. They hurt so bad. Pain from a muscle is relentless, and people don't realize that. A lot of people think it's their back joints or, you know, like a lot of times it's muscle. It could be disc, it could be joint, but muscle pain hurts. Can you just quickly just go through what happens when you have a lower leg on one side and how that going up the chain affects the muscle tone and the curves of the spine?
So one of the things that when Jenny mentioned leg length discrepancy, there's structural leg length discrepancy and there's functional leg length discrepancy. They are really different. So if you take a look at the general population, I think what the research shows is that a real structural leg length discrepancy is not necessarily that common. So it's not a structural leg length discrepancy, but it's a functional alteration in where the pelvis is, where the ilium is on the pelvis. So if I'm having muscles tighten up in my face and my neck on my right side, it translates all the way down to the pelvis. And since so many of those muscles span the entire trunk and extend all the way down to the top of the pelvis, it can pull the pelvis up on that side. So it looks like it is a leg length discrepancy, but we don't know for sure if it is or isn't. So one of the next things we're going to be doing with the aqualizer study is trying to figure out how much of this is structural, a real leg length discrepancy where the femur and the tibia are different lengths, or are the muscles as they being fired up in the face and coming all the way down and attached on the pelvis, twisting the pelvis or lifting it on one side to make it look asymmetrical, to make it look different. So that's the next stage of the study that Jenny are working on, is if this is a real leg length, structural leg length discrepancy, which we don't think it probably is, because how would 80% of these disappear? How is your leg suddenly shorter or longer structurally. It isn't. So there's a lot of muscle feed coming from the top down onto the pelvis, altering its position in space. So as I said, Jenny, it's not a real leg length discrepancy. Maybe 20% of those patients that didn't correct are structural leg length discrepancy of a couple millimeters or so. But
Right.
at least 80% of them, Jenny, I feel, are probably related to a muscle pulling on the ilium or the pelvis on one side and lifting it. So that's what that's the next phase of the study. So we're going to try and figure out, tease out the factors from top to bottom that are having that happen. Yeah. And then tease out for the patients who didn't correct, why didn't they? Yeah.
Right. So we're going to be using a palm device, which is researched already, and it's reliable. It's done, they've done the research on it. I just purchased it, Bill, yesterday.
Oh, good, good.
It's a way for us to say, okay, this isn't as scientific as using a device that's already been vetted and works well and is reliable. So
Yes. What Jenny is saying is that we were using palpation before. Now we're going to use a palm device, PALM device, which actually will sit on top of the iliac crest and give us a degree measurement. So we'll increase our degree of accuracy.
Yeah.
And then we'll also check the pelvis when patients are standing and sitting and see whether one side of the pelvis is smaller than the other, which we call a handy pelvis. Yeah.
Right.
Yep.
So we're also trying to tie in Mariano Roccabato. You know, we're both students of Mariano, and Mariano has always talked about the atlas and the OA and the upper cervical spine. So a different phase, like we're doing this in phases, little by little, we're going to get to more and more information that I think would just be amazing for dentists and PTs to really get. But when there is a rotation of that first vertebra, you have the atlas right under the skull of OA. So you want to have an even atlas so that the mandible kind of hangs evenly, that there's no cant. But there's not good research that shows, okay, when there's a right rotation, that transverse process of atlas on the left goes forward and up, and that the occlusion is going to be hitting harder on that side when the person brings their teeth together on that left side. So right rotation would cause a first hit on the left of their bite, and correcting it, you should see an even, no rotation. So that's one phase, is that we're trying to get a CBCT cone beam machine that we can also use to kind of learn even more of what exactly is happening in the upper cervical spine. Bill, do you want to add anything to that?
Well, I think that that these changes that are going on as far as the bite is concerned, and where the maxillary mandibular teeth are these changes are happening in 3 dimensions. So I always tell dentists and people I'm talking to that the cranium and the skull, that's like Apollo, and the lunar module, and the mandible is a lunar module, and it's always trying to match up with the best fit and come together. So not only these changes happen with the head tilt, that would be just from the front, the head's just tilting, but when the head tilts like that, the whole skull rotates to the other direction. So it's taking your maxillary teeth way off to one side, and now every time your teeth come together, not only you have to go shift way off to one side, come up and meet, and then come down, and you go right back. So so you're getting more than just a side impact. You're also getting a whole shear twist of the cranium in a circular manner, taking your maxillary teeth away from the mandibular teeth. So it's a 3D complex.
I just had a family that way. And what's happening is the mother, they all tilt and they all talk and they're like this. So meantime, the and we've sent them for PT. We've done nasal therapy, eye therapy to
Yeah.
get the posture better, expanded the upper jaw, got rid of the migraines. But it was that getting that atlas and then that pelvis and then the airway to breathe correctly and then make sure the eyes. So I love that you're breaking it down to components because but even families think it's normal because they all look the same and do the same.
Right.
And they're like, but we're all the same. I said, yeah, because you all have breathing disorders for genetically familial breathing disorders. And that's the primary that your whole structure has developed around. But now we got to get these bowls, the pelvis and the cranium in the right position. And that's why I was fascinated when you said the equalizer, because I can see how the bowls, the cranium and now the pelvis are going to be not opposite, not torqued, but more in sync.
Yeah.
Yeah, you need to take away 3D components out of that. And that's really, so what's happening. So when you drop your right ear towards your shoulder and you tip your head, your maxillary, your top teeth, your skull rotates to the left. So if you tip your ear down the right, your maxillary teeth, your top teeth, your head twists left. So you actually leave half your face back behind you. You'll start, when you start looking at these patients, you'll see that one eye is deeper because it's left in the skull. So as the cranium twists, half the face gets left behind.
Right.
And so you start to see those kinds of real structural changes, not only a head tilt, but a head twist. Yeah, and I'm sure, Martha, you've seen that. You start looking, they go, why is that one eye deep in the face and the other eye more prominent?
Constantly, you constantly
Yeah.
see that. And the
'Cause
left side
whole-
more. It just,
That's right. The whole cranium is getting twisted, leaving half your face back behind. Because all of your fascia and your connections want to keep you in midline. So whenever you twist, whenever you add these twists in, what's going on with the skull, you can start to see it if you know what to look for. Yeah.
Right, and the bones will be brought closer together when there's a muscle under stretch connected to two bones. Muscles are relentless. I'm telling you that when you tug on a muscle, it will bring bones together. So it causes these alterations in spinal posture, position of the head and neck. And, for me, it's been an eye-opening. We keep learning every year a little more. None of us know the whole picture, none of us, but we create a team of people that know a little bit about this, and then we collaborate, and we can really change so many people. TMD to me, I think is so common, and it's sad that it's so common. Airway problems, I think, are the root of the TMJ world, of these patients just clenching because of these, narrowed airways that we develop from even infancy. These babies I'm seeing are all mouth breathing. I'm seeing a ton of, tongue-tied babies that are developing mouth breathing habits that become the child, then the adult that has sleep apnea. So it's, I'm just thrilled, Bill. I think you are an amazing person, PT, writer, and just a good overall musician. I can keep going on the list, but I'm so pleased that we are joining forces to do this, because it's a big thing. I think people need to know how difficult it is, but how simple it can be to correct if you have the right people. On your
that Jenny, we were talking about, I've seen most of my people would come into my office, had seen 3 or 4 practitioners before they went into my office. And whenever I got it, and originally all my patients came from dentists, but then they started coming from ENTs and family physicians, and I was doing the screening for the oral surgeons in our area. And I was just consistently amazed that so many people are not getting the care that they need. So whenever I could combine the physical therapy care, get their heads on straight, and then get together with the dentist and get their occlusion addressed and what was going on there, said people rapidly, and get them in the right splint so their joints would get well, said patients got rapidly well. People who had problems for 5, 10, 15 years, usually 90 days, they were 90% better, and people just get rapidly well. So I think, yes, we need that. These people don't need to be hurting and suffering like they are.
Yeah.
It's a shame that it's 2022 and people are still they're not being addressed appropriately. And the dental field's over here, and the physical therapy and medical field is over here, and they've been apart for 100 years, and we've got to get them together. Because
So
the body is one thing. It's not two parts, you know.
you're right.
Patients, from a physical therapy standpoint, patients are walking around without heads. And from a dental standpoint, patients are walking around without bodies. And
That's right.
and you know, we're not dentists and physical therapists. We need to be TMD therapists, you know, TMD practitioners.
Yeah.
About time. We got to know both.
They,
Complex, but you got to know both. And now you got to know airway on top of that. So not only do you know all that, now we need to know everything about airway.
right. That's
I'm
a whole other layer, you know.
That's a whole other layer. You
Mhm.
bet.
So,
Yeah.
you know, just to sum up, you know, I think what's happened with this Aqualizer study is it's showing how many people are walking around clenched. And their occlusion is a big part of their problem. Like they're just clenched and compressing their head, they're compressing their spine. And what we've done is kind of disengage that, let the body, let the cranial sacral system flow, let that fluid system flow without that compression, let the spine move without that compression, disengage the bite, and voila, there's a release in the tension of that occlusion, which allows the pelvis to be free to be more even. And we're going to learn more and more. I'm determined to keep working with Bill to really get more information for the dental and the PT field, so that we can answer these difficult chronic patient questions. That why am I so in pain? Why am I hurting so much? So thank you so much, Bill. Any last words, Martha? Any last words?
It's
That-
about time. It's about time.
It's about time.
Yeah.
About time.
I agree. Bill, any last words?
Yeah, the only thing I've seen recently is I've seen quite a bit of information coming out about biopsychosocial, and I really do think that a lot of TMD patients that aren't being addressed appropriately from a combined PT standpoint are being put in a category of biopsychosocial, and I think it's a shame. I think it's a crime, but it's a good escape hatch. But I really,
It's a crime and a good, absolutely right.
it's just
And
terrible.
especially women.
Exactly.
And now the tall, younger, slimmer men and women, but the young men also, because that tall lankiness is UARS, upper airway resistance syndrome. They always have a TM, they always have clenching, and now their sleep is disturbed. They're insomnic. They're put in the wrong category by the wrong people. And all it is structure first.
It's an escape clause, and I think it's just a shame. It's like the patients that would come into my office with 5, 10, 15 years worth of problems that their symptoms are gone within months, you know. And are all those patients biopsychosocial?
No.
Untreated, people end up with a psychological
Of course.
stress problem that is probably, I hate to say, maybe induced by the practitioner themselves, the practitioners.
Well, you know what? I don't know how I would be if I was in pain all the time.
Oh my goodness.
Okay, I don't know how I would
Same
be.
here.
I'm sorry,
Make it crazy.
but what draws me to a lot of this field is I genuinely want to assist with the pain, because I don't know what that's like. I've had the privilege of having migraines a day to 3 days. I've been
Yeah.
privileged. When I say privilege, is because I was able to reverse them. And it was opening up the bite, changing the occlusion without doing permanent restoration necessarily. But my point being is just living through that pain was wonderful because I can really sympathize of someone who says they've been in pain 20 years. You're like, what? What do you mean? Of course they're going to be affected.
Yes, it's not uncommon. It's not uncommon for the TMD
No.
patient. And as said, when appropriately addressed, many patients, so many patients I saw had so many years of discomfort, rapidly responded.
That's amazing. That's wonderful. It's
And there's
truly
no
wonderful.
and it's not mysterious. It's
No.
mechanical. It's mechanical.
Yep.
Yeah.
A
Yep.
mechanical problem.
Mechanical.
So I want you both to stay on just a moment, but I'm going to say thank you so much. You will hear more from Bill Esser and Jenny Hobson about how the bite and the rest of the body connect and how we can help so many more people with TMJ and airway issues. So thank you for your listening, everybody. Next time, we're going to have an amazing speaker, Dr. Karen Davidson, around rhinometry. So we're going to be talking about the nose and nose breathing and how important that is. So stay tuned and we'll see you next time.
Bye-bye.
Goodbye.
Good night. Good day.
Good night.